Cerebral palsy is the commonest cause of childhood disability and affects a child's ability to move. Children with cerebral palsy have difficulty in coordinating their movements as a result of damage to the brain early in life. This damage could have occurred whilst the baby was still in the womb. It could be because of complications during birth or in the first few days of life. Or it could be as a result of infections such as meningitis and TB of the brain when the child was very young. Children with cerebral palsy present with multiple and complex needs, as the muscles used for eating and for talking are also affected. This means that not only do children with cerebral palsy have difficulties with learning to sit and walk, they very often have difficulties with learning to chew as well. In addition, many children with cerebral palsy have epilepsy and problems with learning. Thus, their needs are complex and present a huge challenge both to their caregivers and families, and to the therapists trained to work with them. Cerebral palsy cannot be cured. Therefore, early support for the family and early therapy intervention can help the children's development and improve muscle control and coordination. Children with cerebral palsy living in poor and rural areas are a particularly neglected and undeserved group. Although they qualify for assistance from the government in the form of care dependency grants, this money is often the family's only source of income, and as a result is not always spent on the child. Caring for a child with cerebral palsy involves many additional costs not associated with non-disabled children, such as frequent trips to clinics and hospitals, special food and disposable napkins. The children remain dependent on their mothers for feeding, bathing, dressing and toileting, and this places a heavy burden of care on mothers, often resulting in mothers feeling isolated, lonely and depressed in coping with day-to-day living. To compound the problem, access to rehabilitation services is difficult in poor rural areas. Not only is transport to the hospitals costly due to the distances involved and the fact that the children have to be carried, but once they get to the hospital, they find that there are not enough therapists to help them. Those therapists that are there very often have little or no experience in working with children with cerebral palsy, as a result of a high turnover of therapists in public service hospitals, due in the main to poor salaries and stressful working conditions. This is compounded by a dire lack of basic equipment like wheelchairs and buggies due to the lack of financial resources. The consequences of inadequate and insufficient therapy are that the children become stiffer and more crooked as they get older. Many develop contractures and deformities, making it impossible for them to sit. But this doesn't have to be their lot in life. There are the skills and resources in South Africa which can be harnessed to change the lives of these children and their families. The South African Neurodevelopmental Therapy Association is a group of qualified physiotherapists, occupational therapists and speech therapists who have the skills and interest in the special needs of the children suffering from cerebral palsy. The therapy is based on the Bobath concept, in which the therapists relate the child's difficulties with moving to the abnormal quality of muscle tone. By applying specific neurodevelopmental therapy methods, the quality of muscle tone in a cerebral palsy child will improve, thus making it easier for the child to move. In many rural poverty-stricken areas in South Africa, there is a desperate need for support in the form of qualified professional therapists. And with this in mind, a pilot outreach project was initiated by a handful of dedicated therapists. A remote, poor area in the far northeast of Limpopo province, Malamulele, was identified as having a dire need for intervention. Here, a small group of dedicated therapy assistants and community-based rehabilitation workers were running a busy monthly clinic for more than 30 children with cerebral palsy. A team of 5 NDT-trained therapists was joined by a research assistant and CP mother from Soweto on a 3-day visit during which they screened and assessed the 30 cerebral palsy children, assessed the need for equipment and put in place the plans for a bigger intervention 2 months later. All this was done with close cooperation with the community workers and the mothers of the 30 children. Then, in November 2005, a group of 10 volunteer cerebral palsy therapists travelled to Malamulele Hospital for 5 days to treat the children and to provide them with the equipment they needed. The equipment included special prams which the hospital was able to supply, walking frames, standing boxes to enable the children to stand, and splints to try and straighten out the children's limbs. Each child received daily intensive hands-on therapy and in addition was individually fitted with all the equipment and splints he or she needed. The therapists worked closely with the local rehabilitation staff at the hospital and with the child's main caregiver. In most cases, this was usually the child's mother or grandmother. By the end of the week, each caregiver had been taught how to continue working with the child at home and how to use and care for the equipment. Each child was assessed before the treatment started and at the end of the week and again 2 months later to see whether there was any improvement. The assessment included a formal evaluation which could be scored, parent questionnaires and a random home visit to see whether the equipment which was issued was helpful and being used at home. All the children made significant improvement during the week, and they continued to make progress in the months which followed the week of therapy. This was due to the deep commitment of the mothers who continued to work with their children at home and follow the program of activities and suggestions they had been taught. The mothers commented that their children were less stiff, and so it was easier to do everyday things like bathing and dressing and feeding. There is little doubt that the pilot project proved that providing a week of intensive therapy to cerebral palsy children, combined with training mothers and local rehabilitation workers and providing all the necessary equipment, made a significant impact on the cerebral palsy children and their families. The children improved significantly, and 2 months later they were continuing to show progress. A follow-up visit 1 year later is necessary to see how the children are doing and to take them a step further. There are many more areas just like Malamulele throughout South Africa. Children with severe disabilities living in very poor areas with little support or help. Mothers are desperate for practical help and assistance and so are motivated and keen to learn and to know how they can help their children to develop to their full potential. By working hand in hand with therapists who have the skills and experience, so much can be achieved and the lives of the child and the family richly enhanced. It is clear that there is a desperate need for similar interventions in many rural areas in South Africa. However, standing in the way of making a significant and lasting impact in these areas and in the families is a lack of financial resources. Should this be forthcoming, it will enable troopers to broaden the base of volunteer therapists and extend their outreach to those areas, thereby making a life-changing difference to thousands of cerebral palsy children and their families.